I'd like to introduce our next speaker, Dr. Chen, who is Associate Professor of Laboratory Medicine and Pathology and a consultant in hematopathology in the Special Coag Lab, where he is co-director. Dr. Chen.
Morning, everyone, and I'm going to continue the talk, and I'm going to move further into the esoteric testing, meaning many of the lab testing I'm going to describe might not be within your laboratory if you're not in the reference lab setting. So I have nothing to disclose, and then so basically I have two goals. One is by the end of the talk, we would like to know the limitations of standard coagulation laboratory testing and indications of esoteric testing for diagnosing bleeding disorders. Second one is using an algorithmic approach to properly select esoteric testing to diagnose bleeding disorders. So my general approach is actually to start with reviewing patients' clinical, personal, and family bleeding history and concurrent disease, and then do the standard or routine coagulation testing, and then accumulate the results and move to the next stage, which is to select the pertinent esoteric testing. So today, I just based on our experience about the request for esoteric testing, so I'm going to describe the four subtopics. One is primary fibrinolysis, acquired von Willebrand syndrome, platelet disorders, and very briefly on the molecular testing. So first with primary fibrinolysis, I'm going to go very quick to the mechanism. So this is a very delicate system. So the green coated enzymes are actually moving the positive factors, and under the red there's a pi1 and alpha-2 antiplasmin are inhibitors. So any disruption of this delicate system can cause bleeding. So when we're talking about barren fibrinolysis, we're talking about rare hereditary disorders. They're usually involved in deficiency of alpha-2 antiplasmin, deficiency of factor 13, deficiency of pi1. Factor 13, you can think that as a clotting factor. However, recent study have shown it's actually also important in fibrinolysis. And secondary causes are way more common. It is because of the aberrant expression of fibrinolytic protein or activation of this fibrinolytic pathway. And then usually there are associated diseases such as amyloidosis, lymphoma, myeloma, cancer, liver disease, fibrolytic therapy, trauma, and certain surgery. For the hereditary disease, they're exceedingly rare. This is a very sort of a summary of reported cases. And many of the patients or family have a moderate to severe bleeding. But based on the nature of the case report, I think there's I call the report bias of this particular entity. So in bottom line, is disease, hereditary side of things is very rare. And then regardless whether this is acquired or this is a hereditary, usually these patients do not have a profound abnormal coagulation results. Usually they have normal platelet counts, normal clotting times, normal factors, maybe slightly consumptive deficiency of fibrinogen, maybe elevated D-dimer if the patient actually having an active bleeding, and then negative soluble fibrin monomer complex. And then there's a screen test we do, it's called clot lysis or clot stability assay. Basically use 5 molar urea or monochloroacetic acid to assess the stability of the clot. So usually in these patients, that particular lysis time is shortened. So that's a hint for us to move further to do further testing. So as regard to the esoteric testing for the hereditary disorders, and then here are the three enzymes in this pathway, and then I listed also the pathologic level, not the normal range, but pathologic level that might be indicative of possible or explain patients bleeding. And then they all have the antigen assay by ELISA or latex assays, and then there are also activity assays. For instance, the factor 13, we measure the transglutaminase activity either by ammonia release or biotinylated amine substrate incorporation. So there are 2 commercial kits available right now. And then for the alpha-2 antiplasmin and pi1, the assays, even though they're all different names, but the principles are only two. One is plasmin amidolytic assay, which is a chromogenic assay. The other one is plasmin binding activity assay. So regardless of the flavor of different tests, these are the main principle of these two assays. And interestingly, these different assays, including antigen and activities, are scattered among different reference labs. None of the reference labs actually provide all of these tests. So sometimes I felt that the primary fibrinolysis can be difficult to be distinguished from DIC in certain clinical scenario. And many times the standard coagulation testing might not be able to distinguish these two. So maybe esoteric testing is needed to answer these questions. And then for the primary fibrinolysis, we already discussed many of the standard tests are normal or slightly shortened or prolonged, or it's not very abnormal, except for in many cases, especially for the acquired ones, we do see decreased consumptive deficiency of plasminogen and alpha-2 antiplasmin deficiency. For the DIC, there's because of the concurrent coagulation activation and also fibrinolytic cascade activation, you see very profound abnormality of clotting times, decreased coagulation factors, shortening of the clot lysis times, which is similar to the primary fibrinolysis, and also decreased antithrombin, plasminogen, alpha-2 antiplasmin, and maybe if we can, at some sort of a later phase, we can see the schistocytosis by the peripheral smear review. And then sometimes when we're at the reference lab setting, we're trying to differentiate these two. Sometimes we felt that a quick look at these two, antithrombin and the plasminogen level, can give us a hint which direction might be going. So this could be potentially useful. So for primary fibrinolysis, we start with a bleeding pattern, and then trying to evaluate concomitant diseases, lymphoma, amyloidosis, and then we look at the lab results. In many cases, could be very subtle, and then we will perform the esoteric testing involving those players. And antithrombin and plasminogen may be helpful when we're dealing with acquired primary fibrinolysis. So now let's move into acquired von Willebrand syndrome. And Dr. He already described this table, and I felt that the top three are the most common in our experience. So acquired von Willebrand syndrome can be seen in autoimmune-based or lymphoma-based process, and also it can be due to the high shear stress in cardiovascular conditions. For instance, the aortic stenosis, and recently very high prevalent left ventricular assist device patient population. And then thirdly, I think very common in marked thrombocytosis in patients with ET and many other myeloproliferative neoplasms. And then the other etiologies are relatively uncommon. So even though we spent in the literature a lot of time and energy to study the congenital von Willebrand disease, but in my opinion that the guideline derived from the congenital von Willebrand disease might not work perfectly for acquired von Willebrand syndrome. So here I presented to you a very random snapshot of what we usually see in the lab. So I have a normal control, I have a LVAD recipient, I have a patient with a severe aortic stenosis, and I have a patient with marked thrombocytosis. Platelet count can be as high as 1 million. And then you look at the results, antigen, VWF ristocetin cofactor activity, and the ristocetin over antigen ratio, which we use to diagnose type 2 von Willebrand disease, they're all normal. And then if you do the multimer analysis, as you can see that the lower three multimers, they're all missing the high molecular weight multimers. So by definition, so they do have what we call acquired von Willebrand factor abnormality, but we don't know whether patient's bleeding, so we're hesitate to call syndrome. So, so therefore, this is demonstrate the limitation of our current testing. And then because of that, we recruited mainly the LVAD patients and then did a ROC analysis using a newer VWF activity assay and antigen as our screen. And then in this ROC analysis, we found if we use latex activity over antigen ratio at 0.8, we have about 90% sensitivity and 90% specificity of detecting possible multimer loss in that patient population. And also, the ristocedin, in our experience, is somewhat insensitive to acquired von Willebrand syndrome in this particular setting. So that's the reason why this is our algorithm to test for von Willebrand disease. And then that's in the middle is the 0.8. That was because of this study. And this has worked well in our experience for patients with severe shear-related acquired von Willebrand syndrome. So recently, we actually asked the question whether that works for the milder form of acquired von Willebrand syndrome. The mildest form in cardiovascular arena is actually mitral regurgitation, highly prevalent, 1%. And so we group them into mild, moderate, severe. And in the severe group, we have 80% of them had abnormal multimers by visual inspection, manual process. And then recently we developed a quantitative method to quantify the multimer loss. I will have no time to discuss that, but that's included in the reference. And then, interestingly, virtually all of the patients in that severe group, severe mitral regurgitation group, had prolonged ADP cartridge PFA 100 closure times, suggesting that PFA 100, which is a local likely to be a local test in your laboratory, could be a very sensitive method to at least pointing to the direction of acquired von Willebrand syndrome in this setting. And then, lastly, we validated the activity over antigen. We can capture about 30% in this cohort, and then meaning that there's still a limitation in the algorithm that even though we put 0.8, but still can miss something in some patient population. So more study and more sensitive tests is needed to address those patients. So basically, the approach is that when we have a patient with GI mucocutaneous bleeding, and we need to understand underlying concomitant disease such as aortic stenosis, and then you could perform PFA 100 locally, and and then we recommend the VWF profile, including antigen activity, and then we look at the ratio, and then we perform multimer. Sometimes we perform multimer even though the ratios are greater than 0.8 in certain cardiovascular patient with certain cardiovascular condition. So if you want to know more about the approach, there's a poster by Dr. Gupta from a Jacksonville group. And so next, platelet disorder. So it has been reported, and then he already illustrated that our current method, PFA 100 or platelet aggregation, has limited sensitivity of detecting platelet storage pool deficiency. So here is our own study, which is done by Dr. Warat in our group. In 2014, we presented it in ISTH meeting. And then in this cohort, we recruited 84 patients with a suspected platelet disorder. 10 turned out to have a storage dense granule deficiency by EM study. And then they all have very broad bleeding spectrum on the listed on the left. And then we look at their platelet aggregation and the PFA results. We found that the sensitivity of these in this patient population, 10 patients, is about 60%, which agree with the literature. So now bring us the other test is a platelet electron microscopy. So we have two tests to do that. One is called a whole mount, and then one is called a thin section. Whole mount is to study and quantify dense granules, and thin section is to study the ultrastructure such as alpha granule in the platelets. So platelet EM was used to study hereditary platelet disorder started in 1960s by Dr. White. And then we were very fortunate that he helped us to validate our assay, and we implement the platelet EM assay recently in September. So basically, the whole mount is very straightforward. We collect the whole blood in ACD tube, and then we prepare platelet-rich plasma, and then we dot it on the on the EM grid, and then we analyze them under the EM. So the calcium in the dense granules will block the electron beam, create a ink dot structure. That's the dense granule. Conversely, these three platelets do not have any dense granules, so this is a characteristic for Hermansky-Putlag syndrome. However, it's not pathognomonic because completely absence of dense granule can be seen in Wiskott-Aldrich syndrome, Chadia-Higashi syndrome, Jacobson-Trussell syndrome, and other storage pool deficiency severe forms. So sometimes our clinician, when they talk with the patient about the platelet dense granule study, it's very hard to convey with the patient the complicated platelet biology and complicated testing. So actually, Dr. White came up with a illustration that normal platelet is just like chocolate chip cookies. The chocolate chips are the dense granules, and the other one, Hermansky-Putlag platelets, are like peanut butter cookies. And in this setting, that the chocolate chips are very desirable. So that's the take-home message if you can get from my talk. So, and then it's fine, easy to diagnose absence of dense granules. It's also important to diagnose mild and moderate decrease of dense granules. So therefore, we need a normal range to diagnose dense granules. In order to have the normal range, we have to be standardize the dense granule calling criteria. So in 2013, we published this in ASH abstract format with the help of Dr. White. We standardized the dense granule calling criteria. The take-home message is that not every dark bodies under the EM is dense granules. So that's for this criteria. And then we established normal range. So we recruited 111 patients with a balanced gender, and then we rendered the normal range cutoff is 1.2 dense granules per platelet. That's after counting 100 to 200 platelets. And then we didn't observe any gender or age differences of the dense granules in our normal donor population. So thin section is a great way to look at the platelet and look at the ultrastructure. We can see their tubular network, alpha granules, mitochondria, and glycogen. And then here's on the right side is the gray platelet. The missing part is that alpha granule, which these are the alpha granules, and this is missing, completely missing. So this is actually a real image. Just 2 weeks ago, we diagnosed the gray platelet syndrome in our practice. And so basically for the platelet EM, if you have a patient with persistent personal bleeding history and a strong family bleeding history, and then including hereditary thrombocytopenia, you might have normal or unusual abnormal platelet function results and no evidence of von Willebrand disease. This is something you could consider. Very briefly about flow cytometry study of platelet. So we already know these mainly the three diseases this test can cover: Glanzmann thrombocythemia due to GP2B3A deficiency, decreased 2 collagen receptors, GP6, and the GP1A2A, and also the Bernard-Soulier syndrome due to the 1B59 deficiency. So recently we validated and implement this flow cytometry glycoprotein profile. So we have 6 markers available. And then we use the ACD whole blood. We first stain them with a fluorescent labeled antibody. We first gate them using scatter. And then we analyze their mean fluorescent intensity. And then we divide that intensity by the median of a normal donor, in this case CD41 fluorescence. And this is exactly the same way we do for INR and for DRVVT ratios. So we're doing this because we felt that giving a percentage of expression level to clinicians is more meaningful than giving them 500 fluorescent units. So therefore, this is our way of reporting. And then this is, we also did a normal range. This is our normal range, usually above 60 to 70%. So this is a disease we're targeting. And then this quantitative assay also will be able to detect a carrier status for some of the glycoprotein deficiencies. So again, flow cytometry is meant you have a bleeding patient. Obviously, you're going to do a local platelet aggregation study. If you see a pattern of Glanzmann thrombocythemia, Bernard-Soulier, or collagen deficiency, you could consider doing the flow cytometry glycoprotein profile to confirm your diagnosis. So the process of EM and all of this esoteric testing experience is, there's a poster by Dr. Juliana Perez Potero, and you're welcome to visit the poster. So finally, very brief on molecular testing. This is brand new. I do not have a thorough experience, so I just want to give you our sort of thinking. This is a key paper, in my opinion, by Dr. Watson's group. So basically, with our best attempt, with our state-of-art technology, we could still only capture about 60% of the platelet disorders. We are still missing 42% of the platelet disorders. We couldn't find any laboratory phenotype. So this is important, about the molecular testing. So if we just say platelet disorders, we can roughly group them into syndromic or non-syndromic. Syndromic meaning that not only they have a platelet disorders, but also they have other symptoms. So this is actually platelet disorder is part of the bigger syndrome. So using these clinical pictures, sometimes we can sort of direct us attention to targeted genes as listed here. And then many of these cases, some of our laboratory testing can be helpful, but in many cases, the results are usually unremarkable. The next group is the platelet disorders that mainly the affected is the platelets in patients. So maybe some of them, EM, for instance, gray platelet can be diagnosed by EM, but many other thrombocytopenia and platelet disorders can only be diagnosed or detected or confirmed by molecular testing. So therefore, I don't have sufficient data to show you our clinical experience, but here is our general approach. We still start with the clinical history, and then we do the available testing, including, in this case, esoteric testing of platelet studies, and then maybe targeted genetic testing. So I think in the next several years, we will see more and more effort to use the clinical phenotype, laboratory phenotype, and then go to the genotype to diagnose diseases, and also at the same time provide annotation to new mutations. So we do have some very limited experience. So here's another study done by Dr. Juliana Perez Botero. You're welcome to look at our experience about that approach. So I covered briefly the four small topics and regarding esoteric testing. And then again, the general approach is start with clinical history, use available laboratory results within your institution or with some other reference lab, and then appropriately select the best esoteric test target to diagnose rare bleeding disorders. Thank you very much.
We can take one quick question. Microphone. Let me hand the microphone here.
The acquired von Willebrand disease due to mitral regurg, do you see fluctuation of the multimers over time, and do you see thrombocytopenia?
Multimer fluctuation pattern?
To the mitral regurg. Well, yes, with severity of disease, I think, or amelioration of the valve problem, they go away.
So basically, we do not see the fluctuation, but there's no fluctuation if you use a visual inspection of the multimer by eyeballing it, but we do not know whether there's a fluctuation if we use quantitative method to measure the multimer loss. So that's unknown at this point. Fluctuation of
with acquired von Willebrand?
We do not usually see thrombocytopenia.
Not typically. Thank you.
Thank you.